Hello and welcome everybody. Tonight is the International Conference Highlights Symposium for ESMO, ASTRO and IMiG. I am Dr. Samantha Bowyer. I'm a medical oncologist. I work over in Perth at Sir Charles Gardner Hospital and Linear Clinical Research. I'll be chairing tonight's session. We have some excellent speakers tonight who I'm sure will give you some informative presentations. I'd just like to make an acknowledgement of country. The Thoracic Oncology Group of Australasia acknowledges the traditional custodians of the land across Australia and pays respect to elders past, present and future. TOGA also acknowledges the Maori as Chandesha Wenu of Aotearoa, New Zealand, and as treaty partners with the Crown as agreed in Te Treaty o Waitangi. I'd like to thank our sponsors for this evening's meeting, and we're very grateful to the support of AstraZeneca and Boehringer Ingelheim for this webinar. TOGA's vision and mission is to eliminate thoracic cancers as a source of death, disability, and suffering, and we'd like to prevent, treat, cure thoracic cancers through research, clinical trials, education, and advocacy. If you're interested in TOGA membership, we represent the full range of professional disciplines involved in caring for patients with lung cancer, clinical trial professionals, and consumer representatives. The membership is open to anyone who's interested in thoracic cancers, and you can join us to conduct research to ensure patients receive world-class care. This is the program of events tonight, where we'll be discussing ASTRO, ESMO, and IMiG updates, and then we'll conclude with a panel discussion and question and answers, and we'd welcome any questions in the chat function. So I'd like to welcome our first speaker, Professor Anthony Linton of the Concord Cancer Centre. Associate Professor Linton is the Academic and Research Director of the Asbestos and Dust Disease Research Institute and a Senior Staff Specialist in Medical Oncology at the Concord Cancer Centre in Concord Repatriation General Hospital. He specialises in thoracic and genital urinary cancers and completed his PhD at the University of Sydney, investigating prognostic factors and new therapeutic targets in malignant pleural mesothelioma. Thank you, Anthony.
Great. Thanks very much, Samantha. And thank you to TOGA for the opportunity to speak tonight. Here are my disclosures. So tonight I'll be presenting on one of the presidential sessions for lungs, really with a focus on EGFR and other targeted mutations in non-small cell lung cancer. And after that presidential, I'll comment on a few of the other things that I found interesting during the meeting. The first is a result of the Optitrop Lung 4 study of sacituzumab versus chemotherapy for patients progressing after an EGFR TKI in advanced non-small cell lung cancer. Now, this is a really interesting space at the moment, and I think we've all experienced that great osimertinib responder who then on finishing is just left with chemotherapy and then a shift from a lucky patient with a smooth clinical pathway to one that falls apart reasonably quickly. Over the last couple of years, we've seen the result of Mariposa 2 with a progression-free survival advantage from using amivantamab chemotherapy plus or minus lazertinib, as well as the results of the Harmony study using ivonescimab and chemotherapy, which also showed a PFS advantage, but the OS advantage or improvement was not statistically significant. Now, sac-TMT in the third-line setting after an EGFR TKI and chemotherapy did see an advantage over docetaxel, and in this study we now assess one step earlier in the chain. Now, sac-TMT is a TROP2 ADC delivering a topoisomerase 1 inhibitor payload, and in this study of non-squamous non-small cell lung cancer with EGFR mutations who'd progressed on either OSI or with an earlier generation of TKI without a T790M mutation, patients were randomized to sac-TMT fortnightly versus standard platinum pemetrexed doublet with PFS as the primary endpoint and stratified according to TKI generation and brain metastases. For the baseline patient characteristics, the groups were reasonably well randomized, so with slightly more exon 19 deletions in the control group, and about 60% of patients having had a third generation TKI in the first line and 30% in the second line. About 20% of the cohort had brain metastases. Now, the primary endpoint saw a doubling of PFS from 4.3 to 8.3 months with a hazard ratio of 0.49, which was highly statistically significant. The 12-month PFS was 32% in the SAC-TMT arm compared to 7.9%. And importantly, this advantage was really maintained across all of the subgroups. However, prior brain metastases crossed 1. And it's important to note that in this study, the only patients who were included had to have had treated and stable brain mets, and untreated brain mets were excluded. There certainly was still a trend to improvement, but as mentioned, it wasn't statistically significant in this small subgroup. The overall survival, although the median was not yet reached in the SAC-TMT arm, had a statistically significant hazard ratio of 0.6, favouring SAC-TMT, improving 18 months overall survival by 18%. 40% of the SAC-TMT group went on to receive pemetrexed, compared to 20% of the control arm going on to receive another ADC down the line. And the response rates on the whole were improved by 18% in the SAC-TMT arm. As we can see on the whole, the side effect profile appears to be pretty similar to chemotherapy, with grade 1 and 2 alopecia and stomatitis the main unique concerns, with 10% of patients also having low-grade ocular toxicity in the SAC group. There were pretty similar hematological toxicities, including anemia and neutropenia, though somewhat less thrombocytopenia. And as in the chemotherapy group, approximately a third of patients went on to require a dose reduction, or at the very least an interruption. So we now can look at this current landscape and add up to TROP-Lung4 into the mix, which importantly has now shown a PFS and an OS advantage. But at the end of the day, we now have randomized data, an OS advantage, and a reasonable side effect profile. But there are some questions. What about the patients with brain metastases? Untreated were obviously excluded. And importantly, this group did not appear to have the same treatment advantage on PFS. So there was the trend there. I think we also need to ask how actually pleasant is having grade 1 or 2 stomatitis, particularly as 2/3 of patients experienced this. But from a different perspective, we need to see whether this drug will actually prove as effective outside of China. And importantly, how other ADCs like Dato-DXd compare in results that we will see coming out over the next couple of years. But finally, post-FLAURA2, and with a movement to chemo Tagrisso as the standard of care, is this trial already going to be out of date? We obviously will not be facing as many situations now where we are looking at comparing this to combination chemotherapy. So actually, perhaps going back to OptiTROP3 will be more relevant where we're comparing SAC to docetaxel. I'll talk about a few of the other small updates that I think have some practical implications. And the first was the updated analysis of the phase 3 ALEX study of alectinib versus crizotinib that Tony Mok presented at this meeting. And this was in ALK-positive lung cancer. Now, this group, for those who don't remember, was effectively comparing first-line alectinib versus crizotinib, and they would be treated until progression or toxicity, with PFS being the primary endpoint, but OS really being what we're going to look at here. And the long story short is alectinib is great, and isn't it great to have an ALK mutation as opposed to perhaps anything else? Now, with prolonged follow-up, we see that the median overall survival is now measured at 81 months in the alectinib group. And that's the main, I guess, takeaway here. And it would have been unthinkable to think that we would have, a 7-year average survival in any lung cancer group going back even a few years. Importantly, that in addition, what we can see is that even if you have CNS metastases, we again know how wonderful alectinib is. That these patients who have CNS mets at baseline are already living for 60 months, and if you don't have a met at baseline in the brain, you live for 94 months on average. So really, it's a super impressive response, and if you do respond, you keep going with that response for approximately 3.5 years. And it certainly really just reinforces the idea that that ALK mutations are the group that are really setting the scene for the best possible survival in lung cancer. I'll touch briefly on North Star, which was a study of osimertinib with or without local consolidative therapy. And this was really quite an interesting one where effectively patients were given 3 months of osimertinib to begin with, and then they were randomized either to osimertinib or osimertinib plus local control. And again, in the clinical setting, we often use this kind of local control, perhaps in people who have oligometastatic disease or in people who are starting to progress just in one space when they're on osimertinib. But this looked at people right from the outset. And one of the key stratification factors was actually how much you had in the way of metastases. And in this group, about 70% of the cohort in each arms, which were reasonably well matched, though more exon 19s in the osimertinib alone group, had more than 3 metastases, which certainly is starting to feel a little bit more impressive, and 30% having less than 3 metastases. The kind of therapy was obviously divided between radiation and surgery. 60% of patients going on having radiation, which was usually VMAT, IMRT, or SBRT, surgery, and a third of patients for which it was almost uniformly a lobectomy that was performed. And when you look at the progression-free survival, there was about an 8-month statistically significant advantage in having local control as well as osimertinib from a PFS advantage. And then when you look and say, well, maybe this is all just dominated by the people who had very few Mets. Well, actually, the advantage was there on both sides. These subgroups weren't statistically significant or were right on the edge of it, but you can certainly still see that 4-month advantage in those who had local control to begin with, even if you had 3 metastases, and again, whether that be surgery or radiotherapy. The final thing to talk about is an update on FLAURA2. FLAURA2 was obviously one of the big updates that came out of World Lung this year, demonstrating the survival advantage. And again, no news to anyone here. FLAURA2 effectively was a phase 3 upfront treatment in EGFR mutant patients and receiving osimertinib, carbo, PEM, or cis-PEM with maintenance osimertinib and pemetrexed down the line, compared to just osimertinib alone. But there were a number of exploratory overall survival analysis that took place looking at what they considered potentially poor prognostic factors: CNS metastases, L858 mutation, bone mets, TP53 alterations, liver mets, and the presence of mutation in ctDNA. So the overall thing that was obviously already presented at World Lung was this improvement in overall survival in the order of about 10 months for those receiving chemotherapy, as well as Aussie, and a hazard ratio of 0.77. So what happens when you start looking at the poorer prognostic groups? Well, really across the board, and I'll flip through these reasonably quickly, is that you will get that survival advantage, even if it wasn't always statistically significant, appeared to be maintained favouring chemotherapy across the group. You see it at CNS metastases, you see it at L858 mutations, you see it in the detection of EGFR ctDNA, you see it for liver mets, you see it in bone mets, and for P53 it perhaps was not as impressive, but really across the board in all of these subgroups. So this really, the takeaway was to suggest that patients will all potentially be suitable to this, but I think it's important to note that there are the obvious poor prognostic factors that don't feature here. ECOG performance status isn't here, age isn't here, and other comorbidities aren't here as well too. So though this in a sense reassures me that these patients who perhaps have these prognostic factors that might suggest a little bit nastier disease, it doesn't really account for all the things that we consider poor prognosis on the way through. And I will wrap up there. Thank you.
Thank you, Anthony, for that informative presentation. I'd like to introduce our next speaker now, who's Associate Professor Venessa Chin. Venessa is a researcher at the Garvan Institute of Medical Research and also a medical oncologist at St. Vincent's Hospital in Sydney. She specialises in genomics and cancer research, and her work employs advanced genomic technologies to enhance cancer diagnosis and treatment. Her research focuses on integrating novel genomic technologies to uncover novel biomarkers and therapeutic targets. She's going to give us a further update on from ESMO on non-small cell and small cell lung cancer. Thanks, Venessa.
Thank you so much. So I'm looking at 4 abstracts today, one in metastatic non-small cell, the Harmony 6 study, then in extensive stage small cell looking at the Delphi 303 study, the addition of ceralasertib to maintenance durvalumab, and then a really interesting study in locally advanced non-small cell. I've got way more slides than I can discuss, so I will skim through a lot of them. So if we look at metastatic squamous non-small cell lung cancer, this is the current sort of state of affairs when we incorporate immunotherapy with chemotherapy. We know that although immunotherapy brings benefit, there is still a lot of room for improvement. Overall, squamous patients do poorly compared to adenocarcinoma patients, have fewer treatment opportunities. Although VEGF is a driver of cancer progression, bevacizumab has not been used in this subtype because of risk of fatal hemorrhage. Ivonescimab is a first-in-class VEGF PD-1 bispecific, and the mutual cooperative binding of both receptors probably has a synergistic effect. So the Harmony-6 study took patients who were treatment naive, randomized them to ivonescimab plus chemotherapy versus tislelizumab, a PD-1 inhibitor, plus chemotherapy with maintenance treatment at the end. PFS was the primary endpoint. Interestingly, the majority of patients in both groups had a central tumor, with hemoptysis seen in roughly 30% of patients in both groups. This is the primary endpoint. The PFS was improved to 11.1 months versus 6.9 months with a hazard ratio of 0.6 and a statistically significant p-value. On the right-hand side, you can see that roughly all subgroups benefited from treatment, including all the PD-L1 subgroups, with the most benefit seen in the TPS 0 group. This is further seen in the Kaplan-Meier plots, where you can see the greatest separation of curves in the TPS less than 1%. Overall survival was 76% versus 66%, with a duration of response was around 11 months in the treatment group. Safety summary, I'll just skip the left-hand side. If you move to the right-hand side and look at the risk of hemorrhage, you can see that hemorrhage was more common in the treatment group, 21% versus 9%, and in the more than grade 3, 1.9% versus 0.8%. We need to mention that one person died from a hemorrhage. So this is a summary. This was a positive study, a study that met its primary endpoint. Although the authors of the study deemed this to be a safe treatment, we do need to acknowledge that one patient died from therapy. The duration of response is relatively short, so interesting to see if this translates to an overall survival benefit. This adds to only one other study showing that VEGF inhibition increases overall survival. Over on the right-hand side, there's a little graphic there on some resistance mechanisms, which is an interesting read. We need to wait for further overall survival data and acknowledge that this was a Chinese cohort. We move on to extensive stage small cell lung cancer. Again, this is a summary of what we're used to now when we combine chemotherapy with immune therapy. We know that adding lurbinectedin adds benefit, that second-line tarlatamab is exciting, but also these are new in the Australian landscape. We also know that small cell lung cancer is an immune desert. There are no T cells, low PD-L1 expression, loss of MHC class 1, which has made immunotherapy a largely disappointing endeavor. So if we look at tarlatamab, this is a bispecific T cell engager, which leads to primary immune activation, which is different to the monoclonal antibodies that we've been using up until now. This promotes an inflammatory microenvironment and sustains immune pressure. Delphi 303 was a multi-arm phase 1 study. So this is reporting on parts 2, 4, and 7, which looked at adding tarlatamab in the induction phase of treatment. In this study, they had one cycle of platinum etoposide and PD-L1 inhibitor, and tarlatamab was added in cycle 2. They could have had atezolizumab or durvalumab as their PD-L1 inhibitor. Just to say the primary endpoints were toxicity endpoints. Apologies. So if you look at the treatment baseline characteristics, you can see that a higher percentage of patients in the atezolizumab group had brain metastases, a higher percentage of patients in the durvalumab group had liver metastases, and there was a higher sum of diameters, so maybe a higher disease burden in the durvalumab group. Overall, the toxicities were what you would probably expect, some slight differences between the atezolizumab and the durvalumab group, but in particular, 60% of patients had CRS in cycle 1. Tarlatamab discontinuation rates were low, and if we look at CRS and ICANS by cycle, you can see that the majority of patients had these toxicities in cycle 1. They tended to be grade 1 or 2 and almost never recurred beyond cycle 1. Overall response rate was 71%, and the swimmish plot shows some deep and prolonged responses. This is looking at the overall survival and the PFS. You can see that the 12-month overall survival is 81%. The 12-month PFS is 43%. And interestingly, it looks like the atezolizumab does better than the durvalumab group, noting, however, that the sum of diameters was higher in the durvalumab group. So this is a summary. The addition of tarlatamab in induction chemotherapy IO led to a response rate of 71%, median PFS of 10.3 months, and a 12-month overall survival of 80%. You can see how this compares to IMpower 133, which had a 12-month overall survival of 50%. This is relatively short follow-up, and we need to wait for more data, but obviously very exciting. I'll just quickly go over ceralasertib. This is an ATR inhibitor. ATR is involved in solving double-stranded breaks. When this is blocked, this causes more double-stranded breaks, replication stress, accumulation of DNA in the cytoplasm, and promotion of anti-tumor immunity. This study was a single-arm study taking patients who were treatment naive, who had completed cisplatin, etoposide, and durvalumab, and had ceralasertib added in their maintenance phase of treatment. A small study of 30 patients where only 25 of them actually managed to receive ceralasertib. In summary, this was a negative study. The PFS was 6.1 months, which didn't meet their predefined statistical endpoint. Overall survival was 73%. I'll probably leave it basically there. They estimated overall survival, so this is not a real Kaplan-Meier curve. This is an estimated curve where they estimated 12-month overall survival of 68%. This is clearly inferior to some of the bispecific data. This did not meet its primary endpoint. This was an unselected population. There are some biomarkers that might be relevant here. Down the bottom is a SWOG study that's ongoing now, which is using some biomarker-directed therapy. So this is a summary here. Really, this is a small study, short follow-up, didn't meet its primary endpoint, but probably this treatment strategy may have legs if we can find a helpful biomarker. So looking at locally advanced non-small cell lung cancer, we know that the addition of neoadjuvant, perioperative, or adjuvant immune therapy adds survival benefit. There's a summary down on the right-hand side of all the studies so far. This is an evolving landscape, but how we manage borderline resectable or unresectable patients is becoming increasingly complex. The MDT-Bridge study took patients with stage 2B to 3B non-small cell and who were deemed either resectable or borderline resectable at their MDT. They were then given platinum-based chemotherapy and durvalumab for 2 cycles and reassessed at that same MDT. Patients who were deemed resectable had 2 further cycles and then went to surgery. Patients who were unresectable went on to chemoradiotherapy, and they all received adjuvant durvalumab. The primary endpoint was the resection rate in patients who underwent definitive surgery. So just a few comments here. This is a non-randomized study. The definition of resectability was subjective and made by the local MDTs. There were 43 sites. Most sites only had up to 2 patients. Most of the patients were resectable up front. There were only 28 patients who were deemed borderline resectable. The borderline status was mainly due to T stage to end stage and 10% due to both. The bottom right is at ESMO guidelines on what is considered resectable for you to have a look at later. Important to note that no patients in this study had N3 disease. There's no real detailed staging or imaging data available yet, so obviously we need to scrutinize some of that as that data becomes available. So this is sort of the money slide on the left-hand side. Of the 56 patients who were deemed resectable, the majority of them remained resectable after their induction therapy and then went on to receive surgery. Of the 28 borderline resectable patients, 23 of those were deemed resectable after their neoadjuvant therapy and went on to receive surgery. And only 5 patients went straight to chemo-RT. If you look at the resection rates on the right-hand side, all patients, the resection rate was 86%. In patients who were deemed resectable at baseline, 93% were resectable. And interestingly, the patients who were borderline resectable, 72% became resectable. Only 5% did not have any curative treatment. The majority of patients had an R0 resection. The rate was lower in patients who were deemed borderline resectable. There is no data yet on what imaging was done prior to that second MDT. Overall response rate was good to the induction chemotherapy. You can see most patients had a partial response or stable disease. The path-CR rate was 30%. So the conclusions really were that this was feasible, this was safe, and that there is potential to convert someone from borderline resectable to resectable. So this is a summary of the data. It was estimated that the clinical impact of this strategy was 82.1%. Some of the questions in my mind: is the adjuvant durvalumab really needed? We know that it's feasible and safe. We know that most patients can proceed to local therapy after induction chemo IO. This is an interim analysis. In the patients where this matters most, the borderline resectable patients, we had the lowest representation, which was a shame, as most of the patients were resectable up front. We also need more clarification on the staging done and what defined resectability across the study. Thank you very much.
Thank you so much, Venessa. I'd like to introduce our next speaker, is Associate Professor Stephen Cow. He's a medical oncologist at Chris O'Brien Lifehouse. He completed his PhD at the Asbestos Disease Research Institute and focuses his research on predictive and prognostic factors in mesothelioma. Stephen is a keen clinical trialist focusing on thoracic oncology and continues translational research in mesothelioma and lung cancer. And Stephen's going to present to us the updates on mesothelioma and thymic malignancies from ESMO and IMiG. Thank you, Stephen.
Thanks, Sam. I've been given the task to talk about mesothelioma as well as thymic malignancy from ESMO and IMiG. And here's my disclosure. So for those of you that don't know, IMiG is quite a boutique international conference focused on mesothelioma only, that happens 2 yearly. And this year I attended both of those conferences. And what I'm going to talk about this evening for the next 10 minutes is really what I've learned over the course of this 2 weeks at those 2 conferences, because I really believe that there's nothing earth-shattering in the field of mesothelioma presented at those 2 meetings. So what I'm going to talk about is what I've learned, which is basically the new staging system as well as germline mutations in mesothelioma. At both of those meetings, we talked about the DREAMer results as well as targeting the Hippo pathway. And at ESMO, there were a couple of thymic abstracts, which I will briefly talk about. So I wonder, do you stage your pleural mesothelioma patients? I suspect not, because AJCC 8th edition, the T descriptor is really quite cumbersome, and you can see that most of the descriptors are not able to be determined by routine staging imaging, such as CT and PET scans, as it talk about invasion of endothoracic fascia, invasion into the mediastinal fat, which is not possible to determine on our images. So what's changing to the 9th edition? I don't think this is completely easy, but I think at least it's a step towards us standardizing the staging system. So essentially, you calculate a p-sum, which is looking at those 3 upper, middle, lower chest cavity, and you look at the axial images to measure the maximum thickness in those 3 areas of your thorax, and you add them up, and that's your p-sum. The other thing that you need to do is to look at the sagittal image, to look at the fissural pleural involvement, and you have a F max here. And based on those 2 measurements, you can come up with those T stages accordingly. And why does it matter? You can see that according to survival, the 9th edition for the clinical T descriptor can discriminate against survival much better than the 8th edition can. And so I think that's a step forward in standardizing our clinical trial reporting. Now, you may or may not be aware, beginning of the year, ASCO guideline was published for management of mesothelioma. And in that, they recommended universal germline testing, which is really not in any of our radar here in Australia. And the reason why they discussed this and recommended that is that up to 20% of mesothelioma patients have either pathogenic or likely pathogenic germline variants associated with a hereditary cancer syndrome, including the ones that I've listed here. And of course, the best known is BAP1 mutation in mesothelioma. Now, as medical oncologists, of course, our question is there any therapeutic implications with presence of germline mutation in mesothelioma? And we have some data, historical data, that suggests that if your patients with germline mutation, they do tend to do better with platinum-based chemotherapy, as demonstrated here on the right-hand side. And so, as we know, now immunotherapy has crept up as our standard first-line therapy for meso. And so the question of the presenter at IMiG was really in the era of immunotherapy, those with germline mutations, should we choose immunotherapy or platinum doublet chemotherapy? So this was a very small study involving 67 patients, of which 48 had chemotherapy and 19 patients had immunotherapy, and this is a retrospective study. And you can see on the right-hand side here that in terms of overall survival, those with germline mutations treated with chemotherapy, they had a superior median survival of quite a whopping 40 months compared to immunotherapy of 25 months, and this was just statistically significant. So from my perspective, I think that's exploratory, it's retrospective, but it does show better efficacy with chemotherapy compared to immunotherapy in those that have germline mutations. And the presenter suggested that this supports the ASCO recommendation of universal germline mutation testing. I think that more data is probably needed for this. Of course, I have to talk about DREAMer because this was an Australian study that a lot of us contributed patients to. Of course, we all know that halfway through the study, Ipi-Nivo came into the market, which prompted a protocol amendment. But essentially, it included treatment-naive mesothelioma patients, which predominantly included epithelioid meso. Patients were randomized to the experimental arm of chemotherapy plus durvalumab versus the standard of care, physician's choice, initially chemotherapy, and later a choice of Ipi-Nivo as well. And the presentation really focused on the part where they're comparing chemo-durva versus chemotherapy. But in my mind, the Ipi-Nivo versus chemo-durva is probably more clinically interesting. But you can see that the numbers are quite small, and we're not really going to get any answer out of that. So the primary analysis is really looking at chemo versus chemo-durva. And you can see that both overall survival and PFS did not meet the statistical significance here, and therefore this was really a negative study. There was no subgroup analysis of histological subtypes because predominantly everybody that enrolled were epithelioid, and only a handful of patients had non-epithelioid meso. And therefore, standard first-line treatment remains Ipi-Nivo in Australia. Hippo pathway. It is a growth suppressive signaling pathway. And if you look at the core of the pathway, you'll see presence of cascades of kinases, such as MST1-2, MAP4Ks, and LATS1 and 2. And when you look at the downstream, it's made up of co-activators of YAP and YAS, as well as the DNA binding protein of TAT1 and 4 in the nucleus. So it's really the interaction of YAP and TEAD in the nucleus that leads to the gene expression, and that's a bad thing to happen. If the pathway is activated on the left-hand side, the kinases are phosphorylated and the downstream co-activators of YAP and TAS remains in the cytoplasm, and they don't localize into the nucleus. So that's good. But when the HEPO pathway is inactive on the right, then phosphorylation does not happen, and therefore YAP and TAS is free to enter in the nucleus, interact with TEAD, and that's a bad thing, as I said. So when you look at HEPO pathway in cancer, it's worth noting NF2, which is sitting at upstream around the MST 1 and 2 kinases. So when it's activated, it really just holds the YAP and TAS in the cytoplasm, and that's a good thing. When you have an inactivating mutation of NF2, then basically you lose this control, and YAP and TAS is able to enter into the nucleus and interact with TIAD. And the importance of that is that NF2 inactivating mutation occurs in about up to 50% of mesothelioma patients. So this supports the development of TEAD inhibitors. There are really two types. One is palmitate binding pocket inhibitors. This is where they inhibit this hydrophilic central pockets. And the other is inhibitors that directly inhibit the protein-protein interactions between TEAD and YAP. And those are the two compounds that were presented at both IMiG and ESMO. So these are the two abstracts that was presented. So IAG 933, you can see, showed a response rate about 12%, and generally well tolerated with 10% of proteinuria. Interestingly, though, there were DLT reported with QTc prolongation in a few patients. The VT3989 study showed a response rate of 26% in, again, a very heavily pretreated mesothelioma patients with very similar profile of AEs. And again, you see proteinuria here and grade 3 and 4 toxicity less than 10%. Now, proteinuria is a class effect. So tiered 1 to 4 paralox is involved in podocyte homeostasis, and that's why you get proteinuria with those compounds. It is reversible and not associated with creatinine increase. And interestingly, despite me talking on about NF2, there was actually no correlation between the presence of NF2 and a response to this treatment in mesothelioma. Finally, thymic malignancies. What do we know about thymic malignancies before ESMO? We know that immunotherapy really should not be used in thymoma due to significant immune-mediated AEs. VEGF inhibitors have activities for thymic carcinomas such as sunitinib and nivatinib. What did we learn at ESMO 2025? Well, there was an abstract looking at perioperative pembro, i.e. chemo followed by chemo pembro followed by surgery, then pembro for locally advanced thymic epithelial tumor. They included both thymic carcinoma and, believe it or not, thymoma. 11 thymoma patients were included, and 2 patients died from myocarditis in this potentially curative setting. Grade 3 immune-mediated AE occurred in 64% of thymoma, and I think this was not a good study to have been done, particularly including thymoma patients from what we know. Phase 2 study also was presented using rivoceranib, which is a TKI targeting VEGF receptor 2. Small study, phase 2, which showed a response rate of 35% overall, similar for both thymoma and thymic carcinoma. I obviously have not used this compound, but if 63% of patients need a dose reduction and 15% discontinuation, it's probably not a very well tolerated drug. So, take home. Mesothelioma, new staging, we should be aware of it. Germline mutation testing may have therapeutic implications. First-line standard of care remains ipi/nivo in Australia, and targeting HEPO pathway looks promising, and I think there will be a randomized clinical trial upcoming in Australia. Thymic malignancy, perioperative IO, not in prime time. IO really should be contraindicated in thymoma in any setting, and NG-VEGF approach remains an option, although it needs to be self-funded in thymic malignancy. So thank you very much.
Thank you so much, Stephen. Our final presentation will be a recording from Professor Shalini Vinod. Professor Shalini is a senior staff specialist and an academic radiation oncologist who specialises in the treatment of lung cancer. She's employed at the Cancer Therapy Centre in Liverpool Hospital and is also a conjoint professor at the University of New South Wales. She is also a TOGA board member and an editor on the Journal of Thoracic Oncology, and she's going to present her ASTRO updates for 2025. Following this presentation, we're going to have a question and answer session, so I'll just remind our participants, if you do have a question, please submit through the question and answer function at the right hand of your screen. Thank you.
Hi, I'm Professor Shalini Vinod from Liverpool Hospital, and I'm delighted to present some highlights from ASTRO 2025. I have no conflicts of interest to declare. The first trial I'm presenting is 10-year outcomes of the revised STARS trial from MD Anderson. The revised STARS study compared two cohorts of patients. The first cohort were those with operable lung cancer up to 3 centimeters in size, who were recruited to have 3 to 4 fractions of SABR. The control group were patients in the same institution that were having a VATS lobectomy and mediastinal lymph node dissection. This was a non-inferiority trial that met its primary endpoint and was published in Lancet Oncology in 2021. Here the group report the long-term outcomes. The mean age in both cohorts was 68, and approximately 80% had adenocarcinoma, and the tumors were less than 2 centimeters in both arms. The median follow-up was 8.3 years. Of note, for those in the SABR arm, all 80 patients had EBUS nodal staging. This was only done in 25% of those undergoing surgery, and therefore some patients were subsequently upstaged to N1 or N2 disease, 11% in total, and this resulted in these patients requiring adjuvant therapy. There was no difference in overall survival or lung cancer-specific survival between the two groups at long-term follow-up. In the SABR arm, there were more patients with local regional recurrence. There were 9 patients in total, and of these, 5 were subsequently treated with salvage chemoradiotherapy, 3 with surgery, and 1 had reirradiation with SABR. So the overall recurrences were double. There were only a couple of patients with local regional recurrence in the surgery arm, of which 1 was salvaged with chemoradiotherapy and the second had palliative systemic therapy. So the take-home points from this study is that through 10 years of follow-up, there was no difference in overall survival, cancer-specific survival, or recurrence-free survival. Although there were more local regional recurrences in patients who underwent SABR, this was salvaged with further therapy in these patients without impacting survival. The initial publication reported higher toxicity results from surgical resection, but at long-term follow-up, there wasn't a significant difference in long-term toxicity and even financial toxicities, which I did not show today. So SABR is definitely an option for patients with operable stage 1 non-small cell lung cancer. The one word of caution when extrapolating this to your practice is these patients had intensive mediastinal staging to make sure they were truly stage 1 and didn't have unrecognized nodal disease. The other practice point is with lung cancer screening coming on board, there may be patients who don't wish to have surgery, and SABR would be a safe and effective treatment option for these patients. So just moving on to the next study, this is one on small cell lung cancer, comparing daily and twice daily radiotherapy in younger versus older patients with limited stage disease. So this is real world data from the Dutch lung cancer audit between 2016 and 2023. They looked at all patients with limited stage small cell lung cancer who received concurrent chemoradiotherapy and then analyzed the outcomes. So this slide shows the comparison between the two arms. In both age groups, the under 70 and 70 plus, those who got once daily treatment did have worse performance status. In the less than 70 age group, they were more often stage 3, and in the 70 plus, they were more often female. Of note, down the bottom, approximately 50% of patients did not have information on whether or not they had prophylactic cranial irradiation. In the whole population, those who received twice daily treatment had better overall survival, so 29.7 months median compared to 24.7 months. However, when they looked at it by age group, the gain in survival was much higher for those less than 70, so that this improved from 26 to 37 months, whereas the difference was much smaller, approximately 3 months in those 70 plus, and this did not reach statistical significance. They did a multivariate analysis to see the factors associated with survival. And for the younger patients, clearly the strongest factor associated with this was twice daily treatment. However, in the above 70s, the fractionation pattern did not impact on survival, but it was more driven by female sex and performance status. They looked at 90-day toxicity, and across the board, if you look, the esophagitis rates were actually comparable between the twice daily and once daily arm. And this is an important point because older studies showed that there was increased risk of esophagitis with the twice daily treatment. But really, with modern radiotherapy techniques, we can avoid this and make it much more comparable to the once daily treatment. Rates of pneumonitis were low across the board, and this was either treatment was tolerable in terms of the 90-day severe toxicities. So just to conclude, 70% of patients with limited stage small cell lung cancer are treated with bi-daily treatment in the Netherlands. I suspect it's not going to be that high in Australia. The median overall survival for those patients was 30 months versus 25 months in the once daily. But the greatest difference in survival was seen in those less than 70. For those who are above 70, the difference in survival was much smaller. So I guess we can consider this in our shared decision-making with older patients with limited stage small cell lung cancer, because logistically, it can be challenging to come for radiotherapy twice a day when there is a minimum of 6 hours between fractions. So either patients have to hang around all day or they have to come and go twice. The next part of the presentation is just a summary of studies that was presented by Professor Dawn Owen on combining radiotherapy and immunotherapy in early stage non-small cell lung cancer. These are the 4 randomized trials in this space. The one on the left, iSaber, has been published. Keynote 0867 was presented at ESMO last year, and the SWOG 1914 was presented at ASCO this year. So again, there is a lot of interest in combining immunotherapy and SABR in early stage non-small cell lung cancer, given that there are potential synergies seen in the setting of oligometastatic disease, and knowing that the predominant pattern of relapse still remains distant or metastatic. So can we identify a group of patients who may benefit from adjuvant systemic therapies, as is seen in the early stage surgical setting? Now, these trials all used different immunotherapy agents and also used it for different periods of time. The iSaber trial excited everyone because it did show an improved event-free survival. This was a phase 2 trial. However, this finding was not confirmed in Keynote 0867. This has only been published in abstract, but there was no difference in event-free survival. And similarly, it was not confirmed in the SWOG 1914 study, which recruited patients at a higher risk, being greater than 2 centimeters, and other risk factors that might have predicted for distant relapse. We await the Pacific 4, which will be the largest randomized trial in this space. So I guess current practice will not change for these early stage patients who are having SABR. And I'd just like to finish off with a poster from the University of Pennsylvania. They report on patients with stage 2 to 3 non-small cell lung cancer, suitable for definitive treatment as determined by their MDT. Of the 323 patients, 111 were eligible for surgery, 36 had neoadjuvant chemotherapy and immunotherapy, and the remainder proceeded directly to surgery. Note, of the 36 who had the neoadjuvant treatment, 23 actually had T3 or T4 tumors, and 17 had N2 to N3 disease. The point I want to make is, of the 36, only 21 underwent surgery, so that's 58%, despite the fact that the majority of cancers, as you can see in the waterfall plot, showed radiological response. Now, the reasons behind this were not stated in the poster, and also they did not say what treatment these patients subsequently received. In the randomized trials in this space, about 80% of these patients have surgery, but in the real world, in an academic center, only 58% did. So I think this should give us pause for thought when we translate trial protocols into clinical practice, and we need careful MDT discussion regarding best treatment for these patients with stage 3 non-small cell lung cancer. So I'd like to finish off there. I'm sorry I won't be available for questions. Have a good evening.
Thank you everyone for your presentations. We now have some time for questions. It's been nice to see some updates that might be more immediately implementable in clinical practice. We've got some questions from the audience, so I might start with you first, Anthony. Question is, for your next new patient with stage 4 ALK positive non-small cell lung cancer, what is your first-line ALK inhibitor of choice? And I might add to that about whether you think the ALEX study helps with some questions around sequencing.
So first, I'd be happy for them that they have an ALK mutation, but I don't think it necessarily helps with sequencing at this stage. And I think what's clear is that crizotinib is not the answer, but of the next generations, whether that be alectinib, brigatinib, or lorlatinib, I think they're all good, and there's no cross-trial comparisons, so it's very difficult to say. Lorlatinib obviously has the best PFS data. I think it's above 50% 5 years progression-free survival, which is pretty impressive, but that comes at the expense of toxicity. For the alectinib, the progression-free survival is more, 3 or 4 years, and that's not bad, but we don't know really what the overall survival of the others is going to look like. So I think it comes down to actually having the discussion with the patient, because whatever you choose, they're going to be on this for a while. Odds are they're going to be on it for, on average, at least 3 years. Lorlatinib is certainly tough, but in a younger, fitter patient who's keen to, minimize their progression, particularly intracranial progression, you'd probably lean towards lorlatinib. In an older patient, I'd probably lean towards alectinib.
Okay, thank you. A question for Stephen now, and potentially you also, Anthony. With the new development of the mesothelioma guidelines underway, will you be proposing staging be incorporated into our Australian guidelines and change any recommendations?
Look, I believe that the new staging system was mentioned in the guideline. I think the challenge about the staging, as you know, traditionally we think staging is going to help us in terms of deciding what we do with management, with somebody can have surgery or systemic therapy. And with the state of surgical intervention, I think in a way, staging is somewhat academic. But I do think that it's useful in terms of advancing the field, in terms of standardizing prognosis and all that kind of things. But at this point, it's probably not going to change our management per se, but I still think that it's a worthy thing for us to do going forward. It is mentioned in the guidelines.
Okay, thank you. And another question has come through for you, Stephen, regarding germline testing in mesothelioma. And obviously this is exploratory data, but are there any particular types or demographics of patients where you'd be doing this now?
Look, there's some guidelines already on FEQ, but the Australian mesothelioma guideline that's about to come out does have some guidance. And certainly, I think if you see a young person with mesothelioma, the guidelines suggest that less than 60 years, you should consider that. If there's a personal history of other cancers that's involved in BAP1, such as renal cell carcinoma and melanoma, then you should probably consider that. And of course, if there's a family history of mesothelioma or other kind of malignancies in the first or second degree relatives, then that should probably be considered as well.
Okay, thank you. I might ask Venessa a question. What do you think the implications for MDT-Bridge are in our current practice? And should we as medical oncologists be promoting neoadjuvant therapy in borderline resectable, and is the evidence strong enough?
Yeah, I think that idea that we've all had where people are not resectable at their first MDT, therefore they should not pursue a surgery, is probably going to change with time. I'm not sure that this study really changes the standard of care. I think we need to learn more about what the staging was, what resectability was, more detail on surgical outcomes and things. But I think we probably are going to, hopefully in the future, be able to identify that group of patients where surgery may remain an option despite them not having resectable disease up front. So I hope it just means for our stage 3 patients, we have more options for them. But I don't think based on MTD-Bridge that I would be changing anything at the moment.
I think Anthony's frozen for a moment. So I might well ask another question to you, Venessa, around the data that you presented for the squamous cell population, the Harmony 6 study. It's nice to see some progress in a tumor with an unmet need. And I'm just wondering what you thought about the exclusions for that trial and how we would implement that in clinical practice.
Yeah, I mean, I think the risk of hemorrhage is still a real one. And I think what would be interesting to understand is whether the people who'd had a grade 3 or above hemorrhage had any previous history of hemorrhage at the time of randomization. So clearly they allowed patients to be randomized who did have some bleeding up front. If there would be some way for us to rationally select patients where this was a safe strategy, I think that this is compelling data. It seemed like it was otherwise well tolerated. There was a significant improvement in the PFS. But, when we think about, we sort of threw out bevacizumab with that risk of fatal hemorrhage, we probably need a better way of identifying the patients who are at the highest risk.
Okay, great. And I might just ask one concluding question to Stephen. Stephen, do you think we will get enough data to support a perioperative approach in thymic cancer if we excluded a thymoma population, as you said, with the risk of immune-related adverse events?
Look, as you know, the thymic carcinoma is relatively rare. And so I suspect that it'll be very challenging for us to get proper data in that setting, is what I suspect. The data did look interesting in the thymic carcinoma subgroup analysis. It did achieve reasonable major pathological response, but obviously it wasn't a randomized study, and therefore it's hard to get proper idea of whether it helps our patients or not. I think there is some emerging data on the state in the metastatic setting, which looks interesting, and we may have to make some extrapolation from that in the perioperative setting. But it's definitely not in the prime time yet.
Okay, thank you. I'd like to thank all of our speakers for their presentations tonight. I hope that everyone's learned something new from the webinar this evening. We'd also like to get your feedback, and if you could scan the QR code and provide that, that would be very helpful. Again, I'd like to thank our sponsors, AstraZeneca and Boehringer Ingelheim, for their support, and hopefully we will see you soon on the next webinar, and hopefully you'll be able to stay on now for our second presentation, which is Advances in Lung Cancer Therapy with CNS Activity. Thank you. Okay, so I'll move on now to introduce the next section, which is Advances in Lung Cancer Therapy with CNS Activity. Again, I'm going to chair this session. I'm Dr. Samantha Bowyer. I'm a medical oncologist over at Perth. And these will be our three speakers tonight who are going to give some presentations. This educational program is supported by the sponsorship of Boehringer Ingelheim, and TOGA is gratefully acknowledging their support for this webinar. This is our program for this evening. We'll be talking about CNS activity and a multitude of different agents. So I'll just do a little bit of an introduction into CNS metastases in non-small cell lung cancer. We know that the rates will vary by stage and molecular subtype of non-small cell lung cancer, and 10 to 20% of our patients with non-small cell lung cancer will have CNS metastases at baseline. And 50% will develop CNS metastases over the course of their disease journey, which has a significant impact on quality of life, morbidity, and mortality. And this is associated with a poor prognosis historically with conventional therapies such as radiation and surgery, as shown on the right of the slide. Well, what has been the issue? Essentially, the blood-brain barrier has been our obstacle to traditional systemic therapies such as chemotherapy. This is an understudied population with often untreated brain metastases being an exclusion from clinical trials. However, with our improved understanding of disease biology and also drug designs, we are proceeding with new therapies that can have the appropriate molecular properties to maximize CNS responses or have indirect effects that aren't dependent on CNS penetration for response within the brain. So our first speaker tonight is going to be Associate Professor Tim Clay. He is going to talk to us about advances in HER2 TKIs with high CNS activity. Tim is a medical oncologist at St John of God Subiaco in Western Australia. He completed his oncology training through the Victorian Medical Oncology Training Group and has an MD at St Vincent's Hospital, Melbourne, and the University of Melbourne. He has a subspecialty interest in the management of thoracic malignancies and is active in clinical trials. I'll hand over to you now. Thanks, Tim.
Thank you very much, Sam. So just in the first part of the presentation, we're going to be talking about HER2 mutant lung cancer and CNS activity of new agents. I've got my disclosures and conflicts of interest here. So HER2 mutations are generally seen amongst non-squamous non-small cell lung cancer, and they make up a small but significant portion of the oncogenic events that we see in non-small cell lung cancer. And historically, these have been associated with poorer outcomes. And like many oncogene-driven lung cancers, there's a higher propensity to development of CNS metastatic disease. The landscape of HER2 mutant events is seen on the plot below. And one of the differences about HER2 mutant events in lung cancer is that unlike other genes where the mutational events are limited to intracellular in the tyrosine kinase domain, you can see oncogenic mutations both in the transmembrane domain and in the extracellular domain. And these mutations are actionable and targetable as well. You also see a small population of HER2 amplification, which is of interest in terms of use of HER2 targeted therapies as well. And similarly, it's about 1 to 2% of patients. The therapeutic timeline for drugs that have been introduced for HER2 is shown below. And HER2 was discovered as a gene and subsequently an oncogene in the 1980s in relationship primarily to breast cancer. And interestingly, HER2 as a mutation in non-small cell lung cancer was found in 2004 during a deliberate screen for HER2 mutations. So it was found at about the same time as epidermal growth factor receptor mutations, but by a deliberate path rather than via a reverse translation. And despite the knowledge of the presence of this mutation for a long period of time, many of the agents that we've had have either lacked efficacy or have had significant toxicity. It's not been until probably the last 3 to 4 years that we've seen active agents in this space. And we've now got 4 agents that have various levels of regulatory approval. So we have 2 small molecule inhibitors, which is what I'm going to be covering tonight, zongertinib from Boehringer Ingelheim and cevabertinib from Bayer. Zongertinib received accelerated approval in the second line in the US in August this month and is now commercially available there on the basis of phase 2 data. Cevabertinib has an FDA breakthrough designation. The other very active therapies are the HER2 antibody drug conjugates, trastuzumab deruxtecan, which again has been available in the United States for 3 years as a second or later line therapy, and a newer agent called trastuzumab rezetecan, which has been approved and available in China for this condition since May this year. And obviously these are both classes of therapy that we're sort of very familiar with in oncology now, and highlighting the differences briefly is really between an oral therapy that the patient takes at home and a clinic-based therapy that's more chemotherapy-like and requires patient attendance. So moving forward, we've had some data readouts from the tyrosine kinase inhibitors in HER2 mutant lung cancer, and this is zongertinib for patients in the phase 1 expansion study, Be My and Lung 01. So again, by way of background, outcomes for patients with CNS metastases with HER2 mutant disease are poor, with 20% of patients having metastases at baseline and 50% developing it during the disease course. And so there were several cohorts that were examined. This data presentation was looking at cohort 1, who were patients who were previously treated and who may have had asymptomatic and stable brain metastases, although not necessarily, and data from cohort 4, who were patients that had active brain metastases, so increasing lesions at the time of enrolment. And this was a single-arm study where all patients received the active therapy. The similarities between patients with and without brain metastases in cohort 1, or the patient groups, were fairly similar, both in terms of age and gender split and the number of lines of prior therapy. Whereas in cohort 4, there were a larger number of patients who were naive to systemic therapy. The racial divide between Asian and non-Asian patients is in part a reflection of the countries where this study was being run, and it's known that HER2 mutations don't have a particular racial preponderance like EGFR mutations do. So the drug was very active systemically. So these RECIST rates are whole body RECIST rates, not including the CNS. And you can see high response rates of low 60s up to high 70%, as well as disease control rate. Specifically in the CNS, for the group of patients in cohort 4 with active brain mets, the RANO-BM response rate was 43%. And across all 58 patients, the response rate was 41%. Disease control rate of 83%. The median PFS in the brain was 8.2 months, which is respectable. Obviously, interest from clinicians and patients will be how we how we think about moving this duration of response further in this patient population, but certainly encouraging efficacy signals here. This is the pooled response rates for patients who had not received prior CNS radiation. So again, the therapy is active in patients with untreated CNS disease. Zongertinib, in my experience of having used this drug in the clinical trial, is generally very well tolerated. The unintended consequences of EGFR inhibition are generally relatively mild with this drug, although liver dysfunction is probably more important to watch for, particularly in the early days, and is managed with dose holds and dose reductions in the usual fashion. The other active agent in this space that is a tyrosine kinase inhibitor is cevibertinib, which is from Bayer. And the data for this compound is coming along in parallel with zongertinib, so the studies are tending to report out at fairly similar timelines. SOHO-1, which was their expansion study in lung cancer, this drug is dosed twice daily as opposed to zongertinib, which is once daily. And the cohorts reported here were important for an understanding of these drugs because it included cohort E, which is patients who've previously received antibody drug conjugates. So very similarly, we can see a range of a female preponderance in these patients, racial split reflecting the countries where the study was conducted, and sort of extremes of age from as young as 29 to as old as 91, and a baseline brain metastasis rate of between 12 to 27%, depending on the cohort. These patients, with the exception of cohort F, which was naive in the metastatic setting, in cohorts D and E, had a fairly reasonable pre-treatment. These are the response rates for patients with brain metastases at baseline. So if you're looking across all patients with brain mets and those without, the response rates are generally fairly similar, numerically slightly smaller in the brain with the cohort E, which is the ADC pre-treated group, but again, generally fairly good response rates. Very high response rate in the small number of patients with brain metastases from cohort F who had not been previously exposed to drug. Cevibertinib has less of the difficulties with liver function, but has more in terms of on-target EGFR side effects, including rash and diarrhea. Again, those are side effects that we're all fairly familiar with as thoracic oncologists, and a key component of this drug reaching clinic will be being alive to those side effects and proactive with management. One other point with both zongertinib and cevibertinib, which is important, is that there haven't been cases of interstitial lung disease with these agents yet, which we know is an active issue with the antibody drug conjugates. Just finish with a case of a patient of mine who's been involved in BMI Lung 02. She's a 42-year-old woman with a HER2 mutation, insertion mutation. And she presented ECOG1, but fairly symptomatic from this pleural disease that you can see here. A number of liver lesions that were not FDG avid, and this lesion in the brain, which was thought to be a meningioma to start with. She started on zongertinib, and she is currently up to cycle 12 with low-grade cutaneous and GI toxicity. She's had a pericardial window for recurrent effusion, but she's gone to ECOG 0, and this is the response rate in her lungs, which has been clinically as impressive as you can see on the imaging there. But also the lesions in her liver and the lesion in her brain have responded as well. So she's now up to 36 weeks of first-line therapy. Obviously, some patients do better than this and some patients do worse, but this has been a very heartening example of the activity of this therapy. So I think in conclusion, It's exciting times in HER2 mutant disease, going from having no active therapies to four agents across 2 classes. Thanks very much, Sam.
Thanks, Tim. I'd like to introduce our next speaker now, Dr. Ali Balasubramanian. He is a medical oncologist at Monash Health and the Peter MacCallum Cancer Centre with a clinical and research focus on thoracic cancers. He seeks to integrate translational research into patient-centred care with his PhD utilising functional genomics to identify novel immunotherapeutic targets in lung cancer. And thank you, Adi, who's going to be talking to us today about emerging agents with CNS penetration.
Thanks, Sam, and thanks, TOGA, for inviting me and the sponsors for such an amazing event. So I'm going to get straight into it to talk about ADCs and TKIs with CNS or brain penetration. So these are my thoughts, my brief thoughts before we launch into the studies and the nitty-gritty. It's heartening as an oncologist to now see so many studies actually include patients with untreated or even active CNS metastases. So we saw just from Professor Clay, the BEAMIAN lung study with active CNS metastases, and some of the studies I'll be presenting, or the majority of them will be in either untreated or active CNS disease. It really mimics our clinical scenarios that we see. Importantly for me, the intracranial and extracranial responses to some of these drugs are very concordant. So what we see, systemically often mirrors what we see, in the brain, and so we can feel quite confident that there is actually drug penetrance going into the brain, and it's actually an effective drug rather than just delaying progression. Oh, sorry. And cross-trial comparisons are still challenging though, because a lot of these studies are still based on post-hoc exploratory analyses. And there's subtle differences in study design, whether it be some studies use the RANO brain metastases criteria, some studies use CNS RECIST. And given these subtle differences, it's hard to make these cross-trial comparisons, particularly when the numbers of patients in these post-hoc and exploratory analyses are quite low. So, as a bit of an outline, I thought we'd start with the broad in the area of precision medicine and talk about our unselected lung cancer patients. And these lung cancer patients are often responsive to antibody-drug conjugates. And the 2 antibody-drug conjugates that I'd like to talk about today are the HER3-DXd, in particular Tuxedo-3, which was presented at ASCO in 2025 and had concurrent publications this year in Nature Med and Lancet. And Dato-DXd. And then we move on to the more narrow, so our actionable genomic alterations, so our EGFR mutations, which includes our EGFR TKI, so zipalertinib, which was presented at ESMO this year, and furmonertinib, and followed by our KRAS G12C tyrosine kinase inhibitors, so predominantly adagrasib, but also an ode to sotorasib, given the Sherlock study with TOGA, where they released some post-hoc exploratory analysis of CNS efficacy. So the first study to talk about is Tropion-Lung01, or more specifically, the CNS exploratory analysis. The Dato-DXd is a TROP2 targeted ADC. TROP2 is also the target of sac-TMT, as discussed in the post-ESMO seminar. The difference with Dato-DXd is that it actually has greater bystander effect, because the deruxtecan actually diffuses through cell membranes and actually gives a more permeable effect preclinically compared to your Dato-DXd. It's highly expressed in lung cancer and various epithelial tumors, and it's also expressed on normal epithelial surfaces. And this just to say that the toxicities are very much expected with mucocutaneous and GI. So the post-hoc analysis of this study was presented at ESMO, and essentially, World Lung. Now, what essentially we saw was that this study included patients with asymptomatic brain metastases and neurologically stable, but they did not have to be treated, which is a critical difference to many studies in the past. And to give you an idea of the prevalence of brain metastases, out of the whole population of 600 and 300 roughly in each arm, approximately 10% had CNS metastases at baseline. And then when you look at measurable disease per RECIST, i.e. the lesion had to be 10 millimeters or above, this number halved. So you're really looking at 10% of the whole population. And these patients often had CNS imaging every 6 weeks in this study. The majority of this analysis were driven by patients with non-squamous disease. And for a post-hoc exploratory analysis, the study groups are quite balanced, probably with the exception of the time from diagnosis to randomization with docetaxel, which patients in the docetaxel arm had a longer time from diagnosis compared to the Dato-DXd arm. So this is our PFS data with Dato-DXd versus docetaxel when we're looking at CNS. Now we can clearly see there's a benefit with CNS progression-free survival when we look at medians of 5 versus 3 months. And on your right there on the forest plots, you can see that again, this is driven by the non-squamous population, and to some extent hampered by low numbers, the EGFR mutant population. The other thing I guess I wanted to touch in this slide is, and draw your attention to, if you look at the box underneath 6 months, you can see that the majority of patients are actually censored by 6 months. So what we're looking at is that, yes, this efficacy, that even with these agents, they can progress systemically before they actually, progress in the CNS. So from a CNS efficacy perspective, these drugs are very effective, but then there's still the issue of acquired resistance. Now here we can see the numbers. So the CNS objective response rate for Dato-DXd was 38%, including 1 complete response. And there were no RECIST-defined responders in the docetaxel arm. And in this study, it was very much driven by your non-squamous population, but also the EGFR mutant populations. So we talked about Dato-DXd. The second ADC that we'll talk about today is HER3-DXd, or patritumab deruxtecan. Again, it's a topoisomerase linked ADC, and except the target here is HER3. So the Tuxedo trial is an interesting one. It's a phase 2 study which has 3 cohorts, cohort A, B, and C. Now, cohort B is the cohort we're going to be looking at. And essentially, this cohort is in recruiting patients with active CNS metastases. Now, interestingly, before I go any further, cohort 3 was actually also published recently in Nature Medicine. And this was actually a study that recruited patients with leptomeningeal disease alone. But the majority of patients here with breast cancer, and only 6 patients with non-small cell lung cancer. But in cohort 2 or cohort B, these patients all had quite significant active brain metastases. And what's interesting about this cohort is that 40% actually had neurological symptoms related to the CNS metastasis. So these are symptomatic patients and not typical of our general trial population. And similar to Dato-DXd, the responses are really driven, and the population and responses are really driven by the non-squamous cohort. And what's interesting to me is that it doesn't matter whether these patients have had previous local therapy, so radiotherapy, and had refractory metastases, or they're de novo intracranial metastases. If you look at the middle waterfall plot there, they all tend to respond relatively well to HER3-DXd. And so this really shows that actually these responses occur irrespective of prior radiotherapy or not when we're thinking about sequencing. And again, consistent with the Dato-DXd studies, if we look at the bicompartmental responses, they're quite consistent with intracranial and extracranial. So if you're responding intracranially, you tend to be responding extracranially as well in these patients. Now, there's been enough data now on HER3-DXd to understand its toxicities, but as previously alluded to by Professor Clay, I put up this slide because ADCs are not without its toxicities, and vigilance is critical when we're using these drugs. There were 10 patients with treatment-emergent adverse events, and that were serious, And 1 in 5 patients had these events that were attributable to HER3-DXd. So we know that bone marrow suppression is a known side effect of HER3-DXd, but it does show that these drugs do come with their toxicities, particularly in a well-pretreated population. So now we've talked about the 2 ADCs. We can now narrow down into our resilient study, which is zipalertinib and EGFR TKI. Now, there's been a slew of EGFR tyrosine kinase inhibitors against various domains of EGFR. And zipalertinib actually has been shown in early phase studies and preclinical data to actually have activity in the exon 20 insertion mutations previously noted, as well as atypical EGFR mutations, so particularly a G719X or mutations. So this study was presented, or cohort C, which was presented recently at ESMO. And this cohort of patients were those, again, with active brain metastases. And in particular, there were a cohort of patients that allowed leptomeningeal disease. Now, historically, when we're in the clinic, there's been that heart-sick moment when we have leptomeningeal disease and they're automatically excluded from clinical trials. But to me, this is actually a real step forward where we're recruiting patients of the highest need to these studies. And so you can see that the exon 20 mutation was the most represented in this cohort, 56%. Below also the few of the other uncommon activating EGFR mutations were also covered in this study. Again, 1/3 of the patients responded in the study. So we're seeing a pretty consistent theme across the seminar, where it's 30 to 40% intracranial response rates. And again, the responses is quite concordant with the extracranial disease. What's particularly of note for me is that within the responders, actually 2 out of the 5 had leptomeningeal disease at baseline. So this is actually quite a highly active drug for those with leptomeningeal disease. And toxicities are very similar with zipalertinib to previous EGFR tyrosine kinase inhibitors. But we should note that unlike the studies presented by Professor Clay, there was a fatal incidence of interstitial lung disease with zipalertinib. So again, a toxicity that we need to be mindful of. So furmonertinib, but is zipalertinib alone in its CNS efficacy effect? It's alone in the design of a clinical trial as monotherapy. And so furmonertinib is another 3rd-generation EGFR tyrosine kinase inhibitor. And we can see that this was a real-world study published in the JTO this year. It was a single-center series, and it was quite a heterogeneous cohort. But I wanted to present this study because this study recruited the most patients with an ECOG performance status of 2 to 4. So 2/3 of this patient population who received high-dose furmonertinib, which was 240 milligrams daily, either as monotherapy or in combination with leptomeningeal disease. And we can see that there was a response rate roughly of about 40% using the rhino brain metastases criteria. So we think that furmo also may have some CNS activity. And in particular, and it hasn't projected well there, it looks like patients with monotherapy responded well to furmonertinib with leptomeningeal disease. Now, finally, moving quickly into the KRAS G12C space, we see adagrasib, which is a KRAS G12C inhibitor in the CRYSTAL-12 phase 3 study. Now, this study was a phase 3 study with a PFS benefit against docetaxel for pretreated patients with this mutation. And 1/4 of all patients at baseline had brain metastases. Importantly, though, this study only allowed CNS metastases. And in this population of patients with treated metastases, the intracranial response rate was 40%. And this data is actually backed up by the earlier phase study with CRYSTAL-1, where they actually recruited patients with untreated metastases, although it had to be neurologically stable, where the response rates, again, were in the order of 40%. And finally, this slide is just a nod to TOGA's Sherlock study using sotorasib, but the CodeBreak 200 post-hoc analysis of treated CNS lesions was recently also published. Importantly, this was also patients who had treated CNS metastases, so a heterogeneous, a different cohort to the ones we've been discussing. But again, there does appear to be a consistent response rate of 40% in this retrospective analysis, even with sotorasib. So you may wonder why a photo of John Wick is up. Not only is it one of my favorite movies, but on his back you can see Fortis Fortuna Adiawat, and that essentially translates to fortune favors the brave. And the reason I say that is the prospective trials with active brain metastases and leptomeningeal disease really deliver the best chance of unbiased CNS efficacy data. These TKIs and ADCs achieve meaningful CNS control in pre-treated disease, and at some point we may finally move beyond docetaxel with access to these drugs. And optimal sequencing, though, really requires ongoing research and expanded access, and particularly around radiotherapy and otherwise. And this is where biomarker-based research, clinical trials, and compassionate access programs remain critical to guide our practice with these agents. And with that, thank you.
Thank you, Eddie. We'll now move on to our final speaker, who is Professor Tom John. Tom is going to speak to us about progress on CNS efficacy in immunotherapies. Tom is a medical oncologist in thoracic malignancies and genetics working at the Peter MacCallum Hospital in Melbourne. He received his medical degree from Monash University and his PhD also from Melbourne. He completed his postdoctoral fellowship in Toronto before returning to Melbourne. He's also the chair of our TOGA scientific committee. Thanks, Tom.
Thank you, Sam, and thank you, Adi and Tim, for setting the stage. I'm going to skip through some of my, here are my disclosures, but I'm going to skip through some of my initial slides because I think we've already spoken about the fact that the CNS TME is different and that there's already a blood-brain disruption that tumours create. And you can see that with some of the activity of the agents that we've already seen. And furthermore, the CNS metastases to the CNS can actually generate an inflammatory response, and we see that with swelling in the brain. But actually, that inflammatory response is largely immunosuppressive when you look at the molecules involved here. And I would take you through this slide because it's actually a really fabulous paper if you've got time to read it. But they actually show very nicely tumours migrating down the axon. You get lots of axonal damage with CNS metastases, and these are immunosuppressive. And furthermore, we also see that what happens in the primary tumour can actually be different to what happens in the brain. So purple here, these are individual patients, and in purple are those where the primary and the brain met have the same mutations. In dark green are where the METs are different between primary and extracranial METs, and in light green are those where the METs are different in the brain. And you can see just in this brief skim of these figures that there are some tumours where the brain MET is completely different to the primary. So I'm tasked to talk about immunotherapy, and the first question is, does immunotherapy actually penetrate into the CNS? What we really should be asking is, can the immune system penetrate into the CNS? And this study from Georgina Long, which was only published recently but presented previously, really highlights this. This is a group of patients with melanoma treated with either IPI, Nivo alone, or Nivo if you have CNS leptomeningeal disease. And this study clearly showed a benefit to using particularly IPI-Nivo in melanoma. And so very clearly, these are patients who did not have radiation, so patients treated primarily with their immunotherapy, and you can see that there is indeed not only a response, but great survival outcome for these patients. So what about lung cancer? These are the sort of main options that we have in our armamentarium: single agent immunotherapy, combination immunotherapy, IO, chemo plus immuno, adding a VEGF inhibitor, or using radiotherapy. And I'll try and go through these quickly. The upfront, we do know that PD-L1's an important biomarker, even for CNS metastases. These are mainly retrospective studies, and Adi sort of spoke to this, that when you look back on these patients that have CNS metastases, we do see an increased response rate, particularly with the higher PD-L1. But in terms of prospective trial, I'm sorry, and this is another retrospective look at patients from the 227 and 9LA pooled analysis. These are patients who had Nivo, Ipi, and some of them also had chemotherapy on 9LA. That box is around the brain mets subset, and you can see the dots there for yes for brain mets in the top part of that box, clearly showing a benefit for the combination Nivo-Ipi in this group of patients. So what about prospective studies? But this is perhaps the very first study from Sarah Goldberg, which looked at patients treated patients with pembrolizumab on its own. They included patients with CNS metastases, no radiation, no steroids. They did include some oncogenic-driven tumours, and they showed quite nicely that there are indeed responses just using single-agent immunotherapy. But if your PD-L1 was less than 0, none of those patients actually responded. So that's certainly cautionary. We need to be very careful about using immunotherapy alone in that group of patients. What about chemoimmunotherapy? So Ernesto Nadal presented this data called the TESO Brain, which was published in JCO a few years ago. And again, there are higher response rates with the combination of chemo plus immunotherapy, but PD-L1 also does seem to play a role here. And interestingly, when you look at these waterfall plots, you'll see that the majority of patients who achieve CNS response also receive extracranial response, but there are some where it is flipped. So again, a word of caution. And the thing that was interesting from this study is that the median PFS, which you can see here in these curves, is actually not that long. These are patients with de novo CNS metastases, not receiving radiation, and on average, the median PFS here is around 6 to 7 months. So again, even though they might have high PD-L1, that median PFS is not that great. So what about the addition of Ipi to the Nivo? So this is a Checkmate 9LA type combination presented by Ernesto again at World Lung this year. There are 2 cohorts here, some that were asymptomatic with their brain metastases and others that have very low-grade symptoms requiring low-grade steroids. And they all received Nivo, Ipi, and chemotherapy, and they had this primary endpoint of intracranial disease control rate. And they also had a stopping for this, so patients were allowed to continue until disease progression. But I'll show you that they also had a particular statistical endpoint that they were interested in terms of efficacy. So firstly, yes, you see really good responses here, and most responses were concordant here with cranial and intracranial and extracranial disease. Responses here now, nearly 42% for both. But again, the primary endpoint was intracranial disease control rate. They wanted a disease control rate to be much higher than this, and subsequently, this was considered a negative study. So, high response rate was it that there was not enough chemo? They only received 2 cycles of chemotherapy. But even so, when you use this regimen, we're seeing around 30% of patients alive at 2 years, which is still quite extraordinary. What about adding bevacizumab? So this Break B5 study was presented at ESMO just a few weeks ago. Now here, patients, again, this is very real world. You're allowed to get onto this study if you had a lot of symptoms, and you'll see a lot of patients were on steroids at the time of enrollment, and they all received sort of Nivo, Ipi, Bev, and carboplatin, nab-paclitaxel. So, you know, now we're talking 5 agents at once, and if there was good response, then maintenance with just Nivo, Ipi, and Bev. Only 2 cycles of chemotherapy again. Again, I just wanted to draw those boxes around steroids. You can see, you know, 85% of patients were on steroids, and there were some patients who were ECOG-2. So, you know, very real world. This was the primary endpoint. You can see the objective response rate was, you know, it was reasonably high. Confirmed and unconfirmed response rates around 54%, intracranially 43%, extracranially, very deep waterfall plots, and again, most intracranial responses were also paralleled with extracranial responses. The median overall survival here again looks okay, 15.6 months, still not as good as we'd like this to be. You know, 50% of patients alive at 12 months, 40% at 24 months, telling you that if you do benefit, you know, there is a plateau. So here's my sort of summary from these data. So I think it really depends on whether you have a solitary brain metastasis versus multiple as to what you're going to do for your patient. I think if you're planning to use single agent immunotherapy, I certainly wouldn't be doing this if the PD-L1 is low. Yes, you could get away with it if the PD-L1 is very high, but just remember that the PFS is not that great. So you might need to step in with radiation at some point. Combination IO, we don't really have prospective data. There's that 227 data that I showed you. Yes, you could consider this in the PD-L1 low group. I think where the money is in terms of using immunotherapy for CNS metastases that are untreated is the 9LA regimen, and particularly if your PD-L1 is less than 0, but also the Keynote 189 regimen or any of the other combos is certainly reasonable. And perhaps having longer chemotherapy is a better thing if you have CNS metastases. And just bear in mind that going forward, you know, the PBAC did recommend that we're allowed to use immunotherapy now, not just once in a lifetime, but over the course of a patient's journey. And using Nivo-Ipi in non-squamous patients will be an option in the near future. In terms of combinations with VEGF inhibitors, yes, it's an option. Didn't really look as if the Bev added that much, however, and I didn't have time to go into radiation, but it does certainly look like SRS and immunotherapy are safe together. I'll flick through that slide, but just wanted to plug the a meeting that I'm chairing in Tokyo in a couple of weeks' time. There are still registrations available if anyone's interested, and their keynote speakers are Charles Swanton, Daniel Tan, and PC Yang. Promises to be a good meeting in Japan. Thank you.
Thanks so much, Tom. Just before we move to questions, we've got a few polling questions for the audience, just to ensure that we've met the objectives of this meeting. So the first question is, has this webinar improved your knowledge on the CNS activity of HER2 targeting agents? And hopefully you can score that as E. In your view, how great is the unmet need for HER2 TKIs? Based on what you've heard tonight, hopefully we're moving the bar there. And the third polling question, if a HER2-directed educational event was to be held again, which of the following areas would you find the most interesting in learning more about? Okay. We might just spend a couple of minutes with a few questions. I know we're a little bit over time, but I might start with you, Tim. With these small molecule TKIs and the impressive objective response rates, how do you see sequencing with the already approved ADCs elsewhere in the world?
So I think if we're talking about HER2 specifically, none of the agents are approved yet in first line, but we're all expecting that to happen both with the TKIs and the ADCs. And there is some preclinical data around that one can rescue the other. It's a bit of an unusual situation with HER2 where we've got ADCs targeted against the oncogenic protein as against another pathway. And so I think the space we're going to end up in is, should we run these sequentially? Should we do chemo and TKI, then ADC? Is there a role for combination ADC and TKI? I think the rate at which the studies have recruited has shown that there's an appetite for patients to access these drugs. And once we have first-line single-agent data, the move will be to sequencing and combinations. So, I mean, there is some data. The ADCs reached the market before the TKIs, so we've got data on ADC then TKI, but not in the reverse yet. And I'm sure we'll get that through the fullness of time through cooperative trials and registry data. We'll work out how to use these agents.
Okay, thanks, Tim. Adi, a question for you. How would you approach symptomatic brain mets, and do we have confidence to use ADCs as a therapeutic option and emit radiation with the objective response rates that you presented?
Yeah, it's an interesting one. I don't know if we truly have the answer to that. I think that, to me, if someone presents quite symptomatic, I'd still give them, discuss them for consideration of local treatment, because we are still talking about intracranial response rates of 30–40%, and there are a subset of patients that do not respond. So I would still be favoring local treatment. But if it does give us more confidence for those patients where there is quite a burden of systemic disease and we want to crack on, and the neurological symptoms are quite mild, maybe we could consider upfront systemic therapy and leave radiation in hold, sort of like what we do with our EGFR mutant patients with osimertinib.
Okay, thank you, Adi. And Tom, what's your feeling with immunotherapy? Are we confident that our systemic therapy is going to be enough in the brain, or do we still need the radiation oncologists?
Yeah, I think these studies are really cautionary for us, because we certainly, I used to think, look, if you're having a really good extracranial response, you're probably going to be okay intracranially and you don't need your radiation oncologist. These studies really highlight that that's not the case. The median PFS is not as great as we would have thought, and you definitely cannot set and forget. You need to keep scanning the brain and considering radiation if there is growth. Look, the real question is, can you avoid whole brain radiation? And that's certainly a possibility for some patients, and we certainly should be looking to do that where possible. But you really do need to watch carefully if you're not giving the CNS treatment upfront with radiation.
Okay, thank you, Tom. I might bring this webinar to a conclusion, as we're a little bit over time, but if anybody wants to know a little bit more about CNS disease in lung cancer management, we do have a podcast, number 57, if you're interested. I'd again like to thank our sponsors, Boehringer Ingelheim, for the support for this webinar tonight, and thanks everyone for their participation, and we hope that you've learned what you need. Please provide feedback if you can. Good night to everybody.